I've been banging on this drum for 20 years and people just don't believe it. The same reason they don't believe it for the other things, because they say, oh, this is too hard. It doesn't work. It's not sustainable. They didn't really understand the basis of what it was.
Polycystic Ovary Syndrome, PCOS, is the leading cause of infertility in women, and it doesn't have to be. My guest today is Dr. Stephen Palter. He is the founder of Gold Coast IVF. He's a reproductive endocrinologist who spent decades helping women have families, helping couples have families who struggle with infertility, often from PCOS. But now he has a better solution that he has known for over a decade, but that the field is very slow to catch on to. And that's this connection between PCOS and metabolic health. And interestingly, also mental health. So there really is this circle of metabolic dysfunction, which can affect people's mental health and can trigger PCOS and lead to infertility. But the treatment doesn't have to be expensive in vitro fertilization. The treatment can be addressing the underlying root cause of the metabolic dysfunction. And now we're learning that ketogenic therapy, ketogenic diets can help that metabolic dysfunction and can help with PCOS and with fertility, even before weight loss. And Dr. Palter has created tons of information that he just provides out there on social media and other forums for people to learn about this, and he's instituted it in his practice. So let's hear about how Dr. Palter is doing this and how he is changing the face of how we see treatments for PCOS and infertility. Dr. Stephen Palter, welcome to Metabolic Mind. Thank you so much for joining me.
Thank you so much, Bret. It's an honor and a pleasure to be here with you guys.
Yeah, so you are the first infertility specialist we've had on our show here at Metabolic Mind. And I'm really curious to, one, hear kind of what got you into this field, but to just also sort of draw that connection between infertility, PCOS, mental health, metabolic dysfunction, how really these may seem like very disparate diagnoses or conditions, but there's really a connection between them. So I want to get into all of that with you so our listeners can really learn about all this. But first, give us your background. Like, why infertility? You know, you're going through medical school, residency. What got you into this field?
Well, thank you so much. You know, when I started off, I knew when I was a kid that I wanted to be a physician. I guess when I was in fourth grade or so, I was obsessed with biology, and I loved seeing how doctors could figure out problems and solve them and make changes in people's lives. And my father was a psychologist, actually, and he was a classically trained old school analyst. And I knew about this sort of interaction between behavior and medicine, and that fascinated me. And when I went into medical school, I thought I was going to be a neuroendocrinologist. I was fascinated about hormones and how they would race through the body. And there was this interaction between your endocrine system and your behavior. And then I was doing research on it, and they said to me, you know, this is all chronic disease and you like fixing things. It was diabetes and it was thyroid. And they said, you know, these things, we can't fix them. And they said, you know, we just manage it till the patient dies from it. And none of them follow our directions anyway. And at the same time, I saw IVF and I saw reproductive endocrinology. And I said, oh my God, this is like all the best parts of hormones and behavior and psychology. And we're actually creating new lives, and we are partnering with the people, and we're fixing the problems. This was before you guys were fixing diabetes. And so I became fascinated with it. And it's that intersection where we have the most complicated disorders that affect these men and women's lives, but we can figure it out and make a profound change and partner with them really intensely, and then actually fix it and transform their life. And that was the infertility connection, you know, how I shifted from psychology and endocrinology to reproductive endocrinology and infertility.
Wow, that's super interesting. And just to think, you know, if it was now, hopefully nobody would say we can't treat diabetes, right? We can't reverse it. Nobody would say that now, I hope, although some people still might. That could have changed your whole career path.
I think a lot of people still say that.
Yeah. Which, of course, we're learning differently. But so now let's sort of draw this connection between infertility and metabolic dysfunction. Now, obviously, there are a lot of things that can lead to infertility, including anatomical issues and, you know, things that have to be fixed by surgery. But there's also sort of this metabolic bucket, that metabolic dysfunction, like we're hearing about with type 2 diabetes, with dementia, with mental illness, can also affect infertility. So give us sort of the background on that.
And let's open it up. It's not just infertility, but think of it as reproductive health. So for women's reproductive health, the intersection between hormones and metabolism and mental health is profound. And so infertility has been sadly going up. It used to be 10% of the population. It was 1 in 20, then it was 1 in 10, and now it's 1 in 6 couples face infertility. And it's rising. And we are really much better at making diagnoses than we used to be. And we have much better treatments. We have, as you said, surgery, and we have medications. And now we have in vitro fertilization where we put sperm and egg together and we create embryos. So we're great at that. But the number one cause of infertility now is actually a hormonal disorder called Polycystic Ovarian Syndrome, or PCOS. And it is actually the number one most common hormonal disorder of women through their lifespan. So regardless of whether your listeners have infertility or not, a lot of them or their friends or their family members suffer from this. And it's been really poorly addressed over the years. It really has devastating effects both in the teenage years, then the reproductive years, and then as you get close to menopause. And
so we talked about it as infertility, and I shouldn't cut it at just that, like you're saying. So what are some of the other symptoms that women experience?
So when, I actually talk about PCOS now as a metabolic disorder. I call it diabetes of the ovary, and it affects every body system. So if we talk about what the hallmark of the diagnosis is, these are women who, by and large, about 80% of them have obesity, 20% are quite thin. They have irregular menstrual cycles. So their cycles aren't coming. And then when it comes super heavy, and they have high male hormone levels. So they'll have acne or facial hair, and then large percent of them will have infertility. But then if you look at the effect of all these things, if you think about what does insulin resistance, which is key, we're going to talk about, is at the core of how PCOS forms. If you think about all the things that insulin resistance and metabolic disease cause, PCOS is associated with every one of those. So you'll have obesity, mood changes, depression and anxiety are really prevalent, sleep apnea, increased risks of cancer of both the colon and of the uterus, lifetime risks of Alzheimer's and dementia are higher, heart disease, stroke. Every one of these body systems is affected by PCOS, and it's often by this underlying metabolic dysfunction. Now what you're having is these women, if you think of it, 80% of the women who have PCOS have insulin resistance. And even the ones that are thin, 50% of them have insulin resistance. And then all the metabolic effects. So now they also have elevated male hormones. So they get this double whammy that's causing all these things, that this pre-diabetes metabolic syndrome that happens now hits them at much higher rates. So if you look at sort of what's your future risk, they will have about a 5 times increased risk of having diabetes. So about 40% of them will develop overt diabetes by age 40. These are young women. They have 3 times the risk of diabetes in pregnancy. So what we learned, though, is everyone thought it was just the ovary. It was just reproductive. And then we now see that it's the whole body. So if you've got a teenager, just think of what's happening to her. You've got this 16-year-old. Now she's heavy and she's overweight and she's developing acne and facial hair, and her periods don't come. And then when they come, she hemorrhages. This is like devastating to a young woman. Then she goes and tries to get pregnant and she can't in her 20s and 30s. And then when she's in her 40s and 50s, she's developing all of these other organ diseases. And just like diabetes, people used to, the dogma in my field still is, oh, this is, you have this for life and we just treat the symptoms. But once you understand the metabolic connection, the same therapies can be targeted.
Yeah. So what is treatment right now? Give us just the basic sort of overview on current treatment and sort of how well it works or doesn't work.
So I have a huge following on social media. So I talk to a lot of patients and women who are diagnosed and not diagnosed about what their experience is. And their frustration is that we treat symptoms a lot. So the mainstay of therapy is to give women birth control pills because it regulates their cycle and it lowers the male hormones, but it doesn't get to the root cause at all. So it will reduce the acne, it will regulate the cycle, doesn't do anything about the root cause. Then when they go to get pregnant, we give them oral fertility drugs, trying to trigger them to ovulate, and that doesn't work. We give them IVF. And then when they get these diseases, they're just treated as the disease, the heart disease, depression. And by and large, I say to the patients, I can always tell who's got a skinny fertility doctor, because the number one thing that the patients are told is, there's this data that if you lose 5 or 15% of your body weight, it gets better. So the dogma, they say, well, eat less, move more, and lose weight. And when you do that, come back and see me. And it's like as if it was that easy. Like you tell this person who's been struggling with this their whole life and they can't lose the weight because of the hormonal problems. They say, just eat less and come back. And they follow these nutritional guidelines that are so dysfunctional. They follow our traditional pyramid and they eat their healthy grains and they eat their mangoes and oatmeal for breakfast and they get sicker.
Yeah. Although the pyramid now has been flipped essentially. So we'll see how that affects things. But it's such a classic example of truly just putting the Band-Aid on and treating the symptoms and not treating the underlying root cause. Now, is there still some debate about the root cause? I mean, is there some people who say, no, it's not a metabolic condition, it doesn't have anything to do with that? Is that really sort of like understood now?
Yeah, so it is multifactorial. There's a genetic predisposition, there's environmental factors, but I think the relationship that the 80% of people having the insulin resistance is understood. But what I think where our field is failing is, because the doctors don't understand that you can reverse that or change that, they just think that is the de facto biology that you're stuck with. So you've got insulin resistance and you've got high hormones, but they would tell the diabetic, oh, you've got insulin resistance, so go on insulin. So they're telling these women, you've got this metabolic thing, but that's just the way you are. Oh, unless you lose 15% of your body weight and you have bariatric surgery or go on Ozempic, it can get better. But they don't understand that it can actually be changed. I was at a conference and they were talking about the rate going up, and I was speaking, and there was a very famous epidemiologist there who had done research on it. And I said, well, why do you think it's going up? So infertility has gone up. It's doubled. And PCOS, when I first started, was 5% of the population. It's now 15% of all women face this. So number one hormonal disorder of women. And I said, well, why is it? Diabetes is going up, heart disease is going up, obesity is going up. Why do you think PCOS went up? And they said, oh, no, it's nothing related to I said, it's the diet. It's the American diet. They said, oh, no, it's not. We did a survey and, we rang some doorbells and asked people with PCOS what they eat. And I said, where did you do that? They did it in El Salvador and Siberia and said, it wasn't the American diet. And I said, okay, so what changed? And I have pictures at the conference of the doctors with like donuts and literally eating donuts and snack bars. And they said, well, it's not the diet, it's just genetics and toxins in the environment. It's a pure parallel. If you look at obesity, insulin resistance, diabetes, and PCOS, they track with the rates of obesity. So what people don't understand is in our field that is treatable. So the dogma has been eat a Mediterranean heart healthy diet or go plant-based. So if you do that and you lose a lot of weight, your insulin resistance gets better, just like it does with any other form of insulin resistance. But most people who do that don't have that effect. And what they didn't understand is that there's better dietary regimens that actually low carb and ketogenic therapies can actually have the effect that the Mediterranean and the plant-based isn't.
Right. And now there have been a number of publications about using ketogenic therapy, ketogenic diets to treat PCOS, and with documentation of improvement in a number of the hormone levels, and a number of case series about people, restoring their fertility. And even one recent one suggesting that the improvements are not related to weight loss, but just to the lower carbohydrate, the ketogenic effect, and the improvement in insulin resistance. So where would you say this is in the field, using ketogenic therapy to treat the obvious insulin resistance? Is it in its infancy? Is it in its, childhood, teenage years? Where would you say it is?
It's not new. I mean, I've been banging on this drum for 20 years. And people just don't believe it. The same reason they don't believe it for the other things, because they say, oh, this is too hard. It doesn't work. It's not sustainable. They just think it's not a real world solution, because the way they implemented it was eating processed keto foods and, cutting your carbs from 50% of your diet to 25% of your diet. They didn't really understand the basis of what it was, and they were indoctrinated that this Mediterranean and plant-based ways to go. What you're saying about the rapidity is what we see in our patients 100%. So when I first started doing this, I thought it was going to take 6 months to see an effect. And what we see is within 1 month, before they're even losing weight, they'll say that their mood has changed. They'll say that their skin is cleared up. Then they'll tell us, wow, within 1 to 2 months, I'm ovulating when I haven't done that in 10 years. And that's before they lose weight. And that is 100% what you're saying. It's due to the effect on the metabolic insulin resistance pathway, which responds. I mean, I spoke to the people from Virta recently, and we were sharing our experience, and I was asking them how quickly they see the response. It's the same time frame that we see.
Yeah, and I think it's remarkable that you're seeing mood changes, right? And this is what I hear from so many different doctors in different fields. They're not coming to you for mood symptoms or mood disorder, but yet if you help them start ketogenic therapy, they are experiencing improvements in their mood disorder, even though that wasn't sort of the intended effect. And I think that that's so remarkable. But here's, sorry, go ahead.
The rates that are really high. So like depression, I think one of the disservices, again, of our field had been, they assumed it was because of the way the women looked. So what they said is, oh, well, they can't get pregnant, so they feel bad about that. And they're obese, so women feel bad about that. And they have excess facial hair and acne, so that's why they're depressed and anxious. And it's not. When you do standardized tests, they have about a third of these women have clinical depression or clinical anxiety disorders, like 3 times the population rates of it. And they respond to the therapies. And so it's not just as an effect of how they look, it is an effect of the hormones, but also the same insulin resistance and metabolic effect is affecting their mood. And I think it's augmented by the elevated male hormones. And we also see the other thing that's different in PCOS patients is a lot of them struggle with binge eating disorders, not anorexia so much, but binge eating is very prevalent. And you have to try and uncouple all this when you treat it. So if you have, people who have depression and are overweight and are women and have irregular cycles, they should be screened for this the same way as they're treating their depression by treating their hormones together. They're complementary. I'm sorry I interrupted you. You were about to say something.
No, that's okay. So I'm curious now about your experience in your practice, and maybe compared to your colleagues, and throw in a little caveat in how to describe this, because, I mean, let's be honest, if someone comes to you for fertility treatments, doctors can make money doing fertility treatments. If you instead give them dietary advice, you're not making as much money, and it's not reimbursable like fertility treatment. So tell us about your practice, how you've come to grips with that, and how that maybe contrasts with some of your colleagues.
Well, this is a challenge of our field. It's unfortunately complicated, expensive treatments with high success rates that are like the sledgehammer are what everyone focuses on. And as a lot of our field has been taken over by private equity and venture capital and large systems, their metric is their metric is how many cycles they can do and how profitable it is. And that means you do an IVF, and the more IVFs you do and the lower success it is, the more profitable it is. And I've always had a very different approach. I mean, I was a full-time academic at Yale. I was the clinical chief of infertility, and I was a problem solver. I left and opened my own center because I wanted to focus on doing things that what I thought was the best. And if we did a higher volume, we'd be certainly more profitable, but I'm focused on doing it once and doing it right. So I attracted a lot of people who had failures or wanted a more deep dive approach. And we're a boutique. We're not this huge factory. And we do it that way. And it takes a lot of time. And it's a resistance that a lot of people in the field, even ones who believe in this, they feel that it's really a difficult thing to do. I mean, giving someone a pill or coaching them about their diet for months, one's faster. Doing an IVF cycle or coaching them how to do a ketogenic diet is tough. So I started doing this for people who had failed. They had gotten no embryos, or they had gotten no good embryos, or they said, I don't want to go down that path. So I was prepping them for a cycle to do this. And then we started seeing that a bunch of them were getting pregnant on their own. And I was like, this is kind of crazy. And so I started teaching about this, and it was part of my system. I call it the Palter fertility method, where I do an analysis and I treat the root cause, and then we go to advanced things. So word spread about this. And lo and behold, at the same time, I started teaching online on social media because I was seeing so many patients coming in with this horrible misinformation. And where did you learn that? And they said, well, I saw it from an influencer on TikTok. So I started summarizing how to solve problems. And this is one of the big things I teach online. And it grew to about 700,000 followers, over 650 million views of my videos. And people started sending me messages. I followed what you said and I got pregnant. So there is a desire out there. I think a lot of people just aren't familiar with it or don't have the time.
Yeah. So I'd imagine, though, a lot of the women may be on medications to lower their blood sugar. So they do have to be sort of careful and have some guidance when starting ketogenic therapy rather than just doing it on their own if they're on those medications. Are there other concerns specifically in this population with starting a ketogenic diet or precautions that are unique to this group?
I think the main thing is just they should get evaluated to make sure that they don't, if they're struggling with infertility, to make sure that the other basics have been done. So even though you know you have PCOS, have the man check a sperm count, check that your tubes aren't blocked, check your age. Age is one of the top factors in fertility. So get those things done. But most of these women aren't overtly diabetic. So the challenges we face compared to a diabetes reversal group is much less. A lot of these women are just put on metformin or put on Ozempic trying to help their PCOS. And they can really try ketogenic therapies with very, very minimal risk, like less than a 50-year-old guy who's on diabetes medication. The risks to a reproductive age woman is much less. They're much more tolerant. And the other thing is they're much more metabolically flexible. They respond so quickly. So I think there's a lot of people trying this online, but they misunderstand what keto is. So they think, oh, I've got to eat, put butter in my coffee and eat all butter, and just tons of fat. And then they eat keto products from the supermarket that are processed. The modification we make is we do use a higher protein intake than a traditional ketogenic diet. We want them to shoot for about 100 grams of protein because it does support the reproductive axis. Interestingly, we don't measure ketones as much as we use a lot of CGMs, and we're looking at blood sugar spikes. And we focus on that a lot. So we don't have to get into the ketogenic ranges that mental health does, where you're getting really super high. For us, if we can flatten out, and in a ways for a lot of your listeners, if they have depression, anxiety, PCOS, and they're trying to get pregnant, they don't have to do as an extreme a version of keto with restricted protein and restricted carbs. We'll go to almost no carb, but we do fairly high protein. We drop their blood sugar and their insulin, and they may be a more moderate ketone level, but they respond even better.
Yeah, that makes a lot of sense, actually, the way you describe it like that. Now you've mentioned Ozempic a couple times. So is there a signal that GLP-1s are also helpful with, caveats of medication versus lifestyle and chronicity and side effects, et cetera? But is there a signal that they are also helpful?
Yeah, I mean, this was really hot on social media. They called it Ozempic babies because women going on Ozempic and getting pregnant and not knowing it. But you're actually not supposed to conceive on GLP-1s. You're supposed to actually have a 2-month washout because there were some animal studies, probably due to the protein malnutrition, that there were adverse fetal outcomes. So no better result of Ozempic than another weight loss comparable therapy. It's not working better than weight loss. It's just enabling these people to do weight loss that couldn't do it on their own. But we see the same degree of improvement of their metabolic numbers and restoration of ovulation and pregnancy faster with a strict keto diet than you have with Ozempic. So it's just basically allowing them to lose the weight. So if they did bariatric surgery or cut their calories or did whatever, it's not Ozempic per se. It's just allowing them to lose weight.
Right. Whereas with keto, there's some evidence that you actually have improvements before the weight loss. And then, of course, you have the weight loss as well. It's almost like a 1-2.
And these women, they'll have really high rates of gestational diabetes. Their kids have higher rates of PCOS if they're pregnant with it. And so the Ozempic, the problem is it fixes it for a little bit of time. And then as soon as they go off it, they're back where they were. So we'd rather teach them a way of eating and a lifestyle that is sustainable for the rest of their life, through the pregnancy and through postpartum. And so many of these women will say to me, wow, I didn't have the postpartum. I followed this kind of diet once I finished. I didn't have the postpartum depression. I didn't have the mood swings that I used to have.
Right. Now your practice is in New York. So you have a physical practice in New York, but you've mentioned a couple times about this information that you've been putting out there for people to learn from. So where do people access this or where can they find it?
So I'm in New York. It's at Gold Coast IVF. That's for people where we are treating them and where we have to do procedural outcomes. I'm licensed in almost every state as well. So a lot of patients start remotely where they are and they come to us for advanced fertility treatments like IVF. But online, it's Stephen Palter, MD, Steven Palter, MD on every social media channel. And I joke, I can tell if my patients are in their 20s, 30s, or 40s if they follow me on TikTok, Instagram, or Facebook. So you can find me everywhere. And then the remote program for metabolic reset for PCOS is PCOS to Pregnancy, which is available at PCOSbaby.com. It's an entire program where we teach them the ketogenic diet. We coach them through it. We have CGMs available. And then we get into things about how to move. We do zone 2 exercise to improve mitochondrial function. We do small amounts of resistance. We deal with sleep apnea, stress, cortisol. So it's an entire 2 to 3 month program to reset them. And the goal is really what I say is that you should not have to come see me for the advanced procedures.
Yeah. Now, when you started your career, did you ever think you'd be on TikTok? Well, I guess TikTok didn't exist when you started your career, but did you ever think you'd be on, social media, on YouTube, creating videos? Like, could you ever have envisioned this and talking about lifestyle rather than like surgeries and procedures?
I never imagined that you could reach an audience, and I never imagined that I could reach patients directly and in 60 seconds that a bit of information could help them change what they do. And what's remarkable to me was I had some influencer patients who said, why don't you just teach them the way you teach me? And I said, I'm not cute. I don't have hair. I'm not skinny. I can't dance. And they're like, no matter what your expertise is, there's someone out there who desperately wants it. And patients take this information and they say, I discussed it with my doctor and I got cured in a 5-second clip. That's the power. Like, I thought social media was just BS, and I didn't realize you can actually if you can filter the scam garbage from the true facts, people can transform their medical lives with that information.
Wow, that is really remarkable. And the word that just keeps popping up in my brain is just hope. And that's what we hear so much in the mental health field, that people have been treatment-resistant depression or not responding for their bipolar treatment, and they sort of give up hope. and ketogenic therapy has given them hope. And I could see exactly the same thing: failed IVF, not able to get pregnant, giving up hope, and then seeing your 5-second video and saying, wait, that's me. And there's a way to fix it that, I've quote unquote tried everything, but not tried everything if I haven't tried this. So now I've got some hope. And I don't know, I think it's amazing that you're out there putting in the extra work to spread the message for that. And I'm sure you feel that, right? You feel that you're giving these women hope.
I hear that all the time. People are often, this is one of my mantras online. People are saying, why did the treatment fail? Why do I have this? And what they say is, that's not curable. That's just the way you are. Or, well, it's just bad luck and we don't know. Nothing's ever just bad luck in medicine. There's always a root cause. And if you delve into it, you can find out what's causing it. And then things that were previously thought irreversible. So, chronic depression, diabetes, anxiety, these are things that you thought you had for life. PCOS, there are interventions that can dramatically change it. I mean, part of where I learned this from, when I was in high school, my mom was a patient of Dr. Atkins. And so I learned about the Atkins diet. And just at that time, I was a resident, I was working in a lab, and we heard about insulin being the core of PCOS. And I said, oh, we could try this. And look at it. It's been like decades to where it's become a mainstay therapy. But there's people who looked for a solution and said, I'm going to try something that makes sense.
Well, it really does make a lot of sense. And unfortunately, medicine isn't always quick to adopt things that make a lot of sense. But it's gaining research basis, it's gaining clinical practice, and certainly gaining from sort of the ground up with people trying it and experiencing it. So thank you for the work that you're doing to help further this. Anything else that you want to leave our audience with?
I think what you said about hope is enormously important. Seek a diagnosis, be an advocate of yourself, look for information online and vet that information. If you see it from multiple trustworthy sources, find a physician who you can partner with to test it, and just don't settle for being told that there isn't an option for you, so that we can overcome things that we never could before.
Yeah. And of course, we'll link to all your sites so people can find you as well. And thank you again. I really appreciate you taking the time to join me here today.
Thank you so much, Bret. It's been a pleasure to be with you.
Thank you for watching. If you want to see more, check out these recommended videos. Also, if you haven't already, don't forget to subscribe to our channel to stay up to date with our content and help us expand the movement. And if you want to sign up for our newsletter, access our resources, read the latest research, or check out the Think Smart framework, click here to visit our website. See you on the next video.